Hello everybody, welcome to the 2020 annual members meeting. I do apologise that we're late starting, and this next section will give you the clue why. Unfortunately, the chairman, Dennis Dunn MBE, who is named on the screen, we're having a technical problem where we can't connect him to the live presentation function. So I'm apologetic about that. We're hoping we can get Dennis to join and get the IT working again in the next few minutes, but I think you'll have to suffer me trying to do his slides justice. So we're going to continue on the basis that you've all been waiting. So a few housekeeping issues first. So first of all, there is an opportunity to submit questions, and you'll be able to do that via the Teams app. If you can submit those questions as we go, and we'll have time for questions and answers at the end of the presentations. We'll be able to bring those up on the screen and walk through each of those, so please do ask your questions as we go. The papers are available and the link is there. Hopefully you've got copies of those already, or you've been able to see them on the website. And the meeting's being recorded, and it's being recorded for our Trust website so that we can offer it to anybody who wants to see it who couldn't make the meeting today. Thank you. So moving on to the next slide. This is the agenda for this afternoon. So Dennis was about to do the welcome and introductions, as I've said, and just walk through the draft minutes. We've then changed things slightly this year in that we thought it would be helpful for members of the public and our governors to see what it's been like this year. So we've got a few guest presenters today. So firstly, Jenny Newman, who's actually one of our governors, but also one of our staff, to talk about what COVID-19 has been like from the front line. We've got the chairman's report, which I'm crossing my fingers that Dennis will join us for. If not, I will take you through that with the help of our company secretary. We've got the lead governor's report from Dr. Catherine Birch, and then again another presentation for you from some of our staff. So we've got Dr. Saif Ahmad, who's an A&E consultant at the Trust, and Liz Huntback, who is the head of transformation. And they're going to talk to you about what it's been like trying to recover and restore everything post-COVID-19 and how we're going to move forward from here on. I'm going to give you a very brief summary of my thoughts on the annual report and the quality report and anything I wanted you to know. And then Ros Davis, who's our Deputy Director of Finance, is standing in for Russ Faberge today, and is going to talk about the annual accounts, the auditor's report, and the forward plan for the coming year. So thank you all for attending and giving your time up. We'll be as quick as we possibly can because there's a lot to get through on the agenda today. So first of all, I just need to ask for approval of the minutes of the annual members meeting last, which was on the 27th of September 2019. I'm not sure whether we're doing this through the question route or through another route, so I'll just look to my able assistants. But I think we're just looking for approval. How are we looking to obtain that approval, Catherine or Caroline?
Yeah, just through the questions. If there's any questions people want to put forward, that would be great using the question function.
Okay. So
otherwise, we'll have to presume agreement.
Okay, thank you. So we'll presume agreement with the minutes of last time unless anybody asks a question in the next minute or so. Apologies, it's all a completely different world this now, isn't it, to being in the same room and being able to put your hand up, but we'll do our best. Okay, so no questions come in, so I'll take those as a correct record. If other questions do appear in the meantime, we can come back to that item. Thank you. What we will do now then is we'll move on to the next part of the agenda, which is the frontline experience of COVID-19 from Jenny Newman. So over to you, Jenny.
Thank you, James. So I'm Jenny and I'm Staff Governor for Nurses and Midwives at MCHT. Thank you for inviting me to share my experience of working on a COVID positive ward during the pandemic. Back at the beginning, at the start of the pandemic, I was working as a pre-operative assessment sister, and this role is integral to the safety of elective patients prior to them having a general anaesthetic. However, when COVID-19 hit, elective activity was vastly reduced. So I was able to be released to go to the wards where voluntary redeployment was an option. So the PEF team, who are our hardworking practice education facilitators at Leighton, were working flat out at this point because there was lots of nurses like me that were willing to go elsewhere, but we needed our skills updating and quickly. So it's been nearly 10 years since I'd nursed on a ward, so they got us back up to speed quickly. And I was put in contact with one of the medical matrons who asked if I was comfortable going onto a Ward 7, well, onto the Ward 7 COVID positive ward. And I went back and discussed it with my family, and we basically agreed if that's where the help was required, then that's where I would go. So the team on the COVID Ward 7 was put together from all areas of the hospital. There were nurses like me from different areas like pre-op, outpatients, treatment centre, other medical wards, other surgical wards, and we all came together with our different backgrounds to focus on why we volunteered to be there to look after poorly patients. So my first day arrived and I was looking after 8 patients, 3 of whom were on the end of life pathway. 2 were extremely poorly and I had to get the critical care outreach team to them, and they all needed a lot of care. This set the tone for the next couple of months. Needless to say, I went home and wept more than once. I think it was an accumulation of the exhaustion, the sadness I felt for my patients, the worry of catching the virus, the worry of bringing it home to my family. But I was fortunate and I was well supported and I had good people around me, and I was exhausted like many colleagues. And then on my days not on the ward, was trying to homeschool 3 young children and support them as well. And it's the only time in my life where I've said I think my husband deserves a medal. That said, I felt really lucky and humbled every day to go to work and give my all to help patients who were very poorly and not allowed to see their loved ones due to only being able to allow visitors if patients were on the end of life pathway. The hospital were amazing at quickly setting up video calling for patients, which were like lifelines to not only the patients but for their family members. Often we'd stay late to make sure patients were assisted with these video calls, and it was proved to be just so important to their mental health and their recovery. The ward helpers, or ward heroes as we called them, were invaluable. They were amazing and they were so good at helping with the video calls, as well as helping in other ways like keeping staff hydrated, as sometimes we could go hours without a drink, and wearing the PPE was hard work, let alone on a 30-degree day in May. But then our numbers started to reduce of patients that were coming in positive to the hospital, and the Ward 7 ward closed the first week of June when our last patient was discharged, and the numbers reduced all over the hospital, and it meant we could go back to our substantive roles. And I went back to pre-op as elective activity was trying to get restarted, and Ward 7 was opened after its deep clean process for its usual cohort and with patients and staff members. The members of the COVID Ward 7 team will forever have a place in my heart. It was an honour to work alongside such caring and selfless individuals. Many of us contracted the virus ourselves, as well as sometimes family members, and we supported each other the whole time. We still have our WhatsApp group and we check in with each other every now and again. And because we had different backgrounds between us, we had a huge skill set, and we shared our knowledge as well as our tears and our joy when a patient got discharged home. And overall, it was a hard time. It was an interesting time, and I had some great people to share that time with, and we got each other through. So thank you for listening, and I'm happy to answer any questions if there is any. No, I can't see any. So now over to Dennis, if he's been able to get on, or back to James.
Thanks, Jenny. By the look of the fact the camera's come back to me, it would appear Dennis is still struggling. I can attest to the fact that he is there. We've been able to hear him by phone, but unfortunately we just can't get the equipment to work. So I'll try and do my best now to pick up Dennis's slides. I know first of all, were he able to speak, and he'll be itching in the background there because I think he can hear. He would be wanting to talk about what a good year for the trust this has been. That there's been a huge number of successes, and I'll try and touch on those in my brief update later. And I know he'd want to talk about the things that Jenny's just mentioned, the contribution of our amazing staff and everything that they've done, not just this year, every year, but this year in particular, given the challenges that we all know about. So he may join us before the end and he'll be able to do that justice, but I'll try and talk you through now some of the items associated with his part of the report as chairman. So the first thing is some changes to the governing body, and these are the elected governors from March 2020. So you can see from the slides the following governors were re-elected for a third term in March. Barbara Beadle for Crewe and Nantwich, Janet Ollier for Congleton, Janet Roach for Crewe and Nantwich, Caroline Birch, who is Staff Trade Union and Staff Organisation Governor. The following governors were re-elected for a second term of office in March. That was Glinda Al-Assadi from Crewe and Nantwich, Tim Ashcroft from Vale Royal, Maureen Leverington, Patient and Carer Governor, John Pritchard, Patient and Carer Governor, Helen Piddock-Jones, Staff and Volunteers, and Nick Boyce-Cam, Staff Governor for Medical and Dental Practitioners. And the following governors were elected for a first term of office in 1920, and that was Yvonne Banks from Vale Royal, Bob Pugh from Crewe and Nantwich, Judith Wright from Congleton, Jenny Newman, who you've just heard from, one of our staff from Nursing and Midwifery, and Valerie Pickford from Patient and Carer Governor. Moving on to the next slide. The following governors have also been appointed to the council, and that's from local partners. And that's a warm welcome to Councillor Gina Lewis from Cheshire West and Chester Council, Councillor Hazel Feddies from Cheshire East Council, Erica Morris from the Community and Voluntary Sector, and Madeline Abbey from the Chambers of Commerce. Welcome to all of those new governors and those serving additional terms. We have had some changes to the governing body, obviously, because a number of governors have left as these have started. Richard Sutton, who was a staff governor in October 2019, Mary Riley from Congleton, who was elected but declined the post in September, Ray Stafford, patient and carer, who resigned in June 2020. And really sadly, Councillor Dorothy Flood from Cheshire East Council passed away in December 2019, shortly having rejoined us in September. Dr. Jonathan Griffiths and Andrew Wilson both resigned as partnership governors for the CCG, and that was prior to the merger of the CCGs into one. Previously there were four. And Dr. Gladys Pearson, partnership governor for MMU, resigned in January 2020. Following the withdrawal of the MMU from the Crewe campus. And Paul Coleman reached the maximum 3 terms of office for a governor and resigned in April 2020. So those were the key changes. Can I just say a big warm welcome, as I said earlier, to those new governors, a huge thank you to those who've continued to serve, and thank you for everything that you do. I've met with a number of you now on a regular basis throughout the year, even in these really difficult, challenging times when we've not been able to meet in person. And I've just been really impressed with the way that the governors have continued to, throw themselves into supporting the trust and joining us on a regular basis, and rightly asking those challenging questions about what's happening and how we're managing things. And your support and challenges is greatly appreciated. Thank you very much. Dennis would normally talk about the trust constitution now and any changes, but I'm going to ask Caroline Keating, who's our company secretary, to do that, because she's better equipped at that than I am, and will be able to answer any questions. So I'll just hand over now to Caroline.
Thank you. All attendees have been sent a summary paper which actually highlighted the changes to the Constitution, and there are a few of them, but they've also been sent a copy of the Constitution itself. So I think really I'd just like to open this up to questions to see if anybody has anything they would like to either comment on in terms of the Constitution or on the changes themselves. So I will wait for a bit because I can see all the questions. Nothing's coming through at the moment. So we can pick up the questions later, but if there are, if there are no questions, then we will take it as the members being content with the changes to the Constitution and the Constitution itself.
Hi, yes. So I'm standing in for Catherine Birch, who I know is listening, but unfortunately not able to connect and talk to you and deliver what she wanted to say to you today. Catherine Birch is our lead governor, and in that role she brings together our Council of Governors. And I know the first thing she really wanted to say to the members and to the trusts and all the staff who are listening is a huge thank you to the NHS and all the key workers who've supported the public, you know, through the whole year, but particularly through COVID. We've already heard from Jenny what a difficult period and challenging this has been, especially for a lot of the frontline workers. And I know she really wanted to pass on her thanks to everybody. The next slide was just a bit of a background about the Council of Governors. So just a bit of information for those of you who might not be as familiar with the structures and processes of the trust as others. The Council of Governors are the elected representatives of you as members. They're a combination of elected governors. We have governors each year where different constituencies from around the area are represented, and also patient and carer representatives. We have staff governors as well. You've heard from Jenny. We have 6 other staff governors, and we also have a number of appointed governors who are representatives of key partnership organisations in the area. Public governors, those voted by members, must form the majority of the council. So we always have that elected representation of the members at the forefront. The governors are not responsible for managing the trust. That's what the executive and management and staff team are at the hospital. Their role is to challenge and ask questions and hold our non-executive directors to account for the performance of the board. Governors, one of their key roles is to represent the views of members, to ensure their voices are being heard, and to provide members with information about what the trust is doing, how it's managing the resources it has, and provide information about its performance and forward plan. You can see on that slide the diagram which explains this governance structure and how the governors feed into that. And I would encourage you to, when you get your voting pack through for governors, it's really important, if you can, to make a vote and support those people who are representing your views on the council. Next slide, please. This slide sets out a bit of what the statutory obligations are of governors. Some of the things we've already mentioned. Our governors are very active here at the trust. They ask many questions on your behalf to the non-executive directors and the board of directors. They meet formally 4 times a year, but they also meet in committees to look at particular areas which the governors have responsibility for. This includes things like managing the appraisal and performance appraisal of the chairman and the non-executive directors, and also the recruitment into those roles, and also how they engage with members and the communications out to members as well. They have many ways they come in and help in the trust. They come in and do things like place audits, looking at the environment of the trust. They attend patient safety walkarounds. They conduct open and honest surveys with patients, and they go to national events and represent you there as well. Next slide, please. So you see here accountability and challenge that the governors bring, which is their key role, and these are some of the ways that they do it listed here. Catherine, our lead governor, attends and sits at the board when she can, so that voice is always there at the highest level, and they really, the governors do focus on keeping the focus of everybody on patient safety, quality and outcomes for patients as well. As you can see there, Catherine's put on at the bottom her opinion on how the trust interacts and deals with governors, that it's an open approach in its interactions and has a culture of transparency, honesty and candour, and that's very much appreciated by the governors and supports them in their role. And I think that's the sort of conclusion that she wanted to draw to today's slides. So if anyone's got any questions, that's the end of those slides in the presentation on behalf of the lead governor. I don't think there's any questions coming through, so I will pass on to the next presenter, please, which is Dr. Ahmad.
Thank you there, Catherine. Thank you. Firstly, I'd just like to say a really big thank you to everyone for being given the opportunity to come in and speak to everybody here today. It's not often as an emergency medicine consultant you get an opportunity like this to speak to large swathes of people that don't work in the department. So it's a really good, hopefully, opportunity for me to firstly express my thanks to the general public during the first wave of the pandemic, but also to hopefully educate those of you out there a little bit about how emergency medicine has managed and moved on, and we're hoping to move on. So if I just move to my next slide, the main background to my chat is just to set the scene pre-February 2020. In the last 10 years, emergency medicine, as everyone's I'm sure aware, we've seen huge increases in attendances to departments across the country, and certainly our hospital at Leighton was by no means an outlier with that. We were very much seeing a large number of increases in patients attending, and there were numerous reasons and factors why this was increasing population, and that accounts for not just houses being built and children being born, but also people are living longer as well. So there's an increase in number of people around, a decrease in what might be perceived as accessing primary care, and also a very much an increasing 24/7 culture. And by that, I'm sort of talking about the sort of Amazon Prime effect, that if I want to order something now and it'll be here tomorrow, then that's absolutely fantastic. So actually, there's no reason why I shouldn't be able to access my healthcare needs in a similar manner. The background, however, was though that nationally emergency departments are struggling with that, mainly because we are the only 24/7 service available, and also because we've been very much the victims of our own success in terms of branding. If you ask a large swathe of people in the community, where would you go if you needed urgent or emergency care, and they would all say A&E. It's a very recognised brand. So that was sort of setting the background to the beginnings of all this, and then this happened. The government very much sent out a message to say, stay at home, protect the NHS and save lives. And a really interesting thing happened. Nationally, and certainly here at Leighton, we saw a similar thing. We had a reduction in about 50% of people turning up through our doors. The initial worry with this was that we were then missing patients that needed to be in our emergency department, being seen by people like myself and my hard-working team that are trained to deal with emergency cases. And nationally, this was also the worry that people were not coming to hospital that should be coming. What actually we then found, if I move on to the next slide, and then the next slide again, is we had a graph, which I'm just going to show you and let you slowly absorb and look at, that showed a really telling picture. Now on this graph, you can see there are three coloured bars, a blue, and orange, and a grey. Now the blue coloured bar at the bottom is very much what an emergency department is designed to deal with. So these are what we would call our acuity 1 and 2 patients. And everybody, I think, would be familiar with the notion of a patient with having a heart attack, having a stroke, suffering a cardiac arrest, having a broken limb that was hanging off type group of patients. And as I say, that's very much what we're trained to deal with. The orange category are people that probably should be with us and require some further investigation and diagnostics, and may go home or may come in depending on what they've presented with. The top part of the graph, the grey, basically represents people that could be seen in another healthcare setting, that if they attended the emergency department, they may not require investigations or treatment. They may just need an assessment and then further advice and support. And they're very much our acuity 4 and 5s. When you look at that graph there, you can see on the top, we've got the adults, and at the bottom, we've got the children. So there were two interesting trends. When you look at the adult graph, you can see quite clearly that around April and the end of March, there is a really marked drop in the grey patients attending the emergency department. And that very much was people heeding the advice of staying home, protecting the NHS and saving lives. But crucially, not accessing emergency care to help that happen. What we have found, though, at the same time, is the acuity 1 and 2 patients in the blue graph didn't massively decrease in the adults, which was reassuring to an extent. It made us believe that the right people were still coming to see us regardless of the general pandemic, but actually the other people that didn't need to come to the emergency department were either seeking extra help through self-care, pharmacy, or indeed NHS 111, which I'll mention again shortly. The trend in children is slightly interesting because if you look at the same time period, the blue bar, which is very much, as I explained, our bread and butter, the blue bar in the children attending emergency departments actually got very, very low to almost negligible in some cases. Again, the initial worry was that there are children out there that weren't being brought to hospital for emergency care. What actually was happening is social distancing and schools closing stopped children doing something that they're very good at doing, and that is spreading bugs and germs. And when you look at the majority of illnesses that children have that are essentially life-threatening, they are infectious diseases, so your meningitis, your sepsis in children. Because they weren't sharing those bugs, they weren't coming. And also because other things that children tend to do, so sporting events, etc., school activities weren't happening either. What the graph then goes on to show is that gradually over the last 2-3 months, we've actually had a return to normal, in that those acuity 4s and 5s particularly are picking back up and are seeking care in the emergency department, certainly here at Leighton and again nationally. That's inevitable when lockdowns eased and people start to go out and do more things, but again it's starting to put pressure back on the emergency department. So moving on from that, and this meeting times really interestingly well with the national pilots that are beginning to filter out across the country. So the next slide will show you a little poster that has been devised by Blackpool, but that I'm pleased to say that Leighton will be following on in October with, and this is something that people may have seen mentioned in various news outlets and in the media of late, and it's the notion about 111 and call first. So going back to the pandemic, for the first time in its history, NHS 111 had more encounters either through the phone service or through its web-based service than it had ever had before. And crucially, more people were accessing that service than were attending the emergency departments for their care. So the plan is, if we can continue to build on that cultural change that people are trying to self-care, look after themselves and protect services, the next phase of this is to develop 111 into a far more dynamic machine for patients to use. What the outcome should be and what the hope will be, certainly when we go live with this, is that for a portion of patients, not every patient, but a proportion of patients who feel that they need to be seen in the emergency department, if they call 111 and go through a process, they may well be advised that yes, you do need to come to an emergency department. However, rather than just turning up and having to wait, you will be given a time slot to come and be seen as any other outpatient service. And the hope with that is twofold. Firstly, we may encourage more people to actually start to use 111 again and use that as their first port of call for anything they feel isn't life-threatening. But also from our own department's perspective, it will give us a little bit of control over managing the volumes of patients that we're seeing. You've all become very familiar, I'm sure, around social distancing and maintaining reduction of numbers, etc., in every walk of life due to the pandemic. One of the challenges that emergency departments have everywhere is trying to maintain safe distancing in a waiting room. And if we have large numbers of the lower acuity patients here, it's harder to maintain that distancing. So by offering appointments, that should hopefully help. On the back of that, and indeed through news outlets yesterday locally, we also have had some really exciting news in that we've been giving some funding to increase the size of our emergency department and actually make it a more modern facility that will encourage and help us maintain that distancing. So that was, fantastically well received news, and we're all incredibly excited about that. I've tried to keep it fairly straightforward and simple. I'm very happy to take questions. Happy for anyone to chip in as well. But again, thank you ever so much for this opportunity. And if I have no questions, then I will quite happily pass on to James Sumner, our Chief Executive. Thank you.
Thanks, Seth. And yeah, great news yesterday for the new build, long overdue. Right, thank you very much. It is actually, for once, my actual turn now, and I'm just going to talk to you very briefly, just some headlines really from the annual report and the quality account. And I think usually I would just pick out the things that I'm particularly pleased about during the year. What I wanted to draw out really was some highlights, the CQC rating being one in particular. You'll know that the Trust now has been rated good for the third consecutive time, which is a real achievement for any organisation, especially one of our size, with the challenges we've got around the increasing numbers of patients attending emergency care, as Seth has just highlighted. So really good news for the Trust. I think particularly proud of the improvement in community services, and for those that have seen the reporting, you'll know that the community services previously required improvement when the Trust took them on, and now in the first full review since they've been taken over, are all rated as good as well, which is great news for our patients in the community as well as in our hospital. So the CQC rating was a really proud moment for all of the Trust and all of our staff, who a really well-deserved outcome. You'll see from the headlines that we achieved our financial plan, or slightly exceeded our financial plan, which again, given the current climate, is a real plus for the organisation. That doesn't mean we haven't got the financial challenges of most organisations in the NHS now, but again, I think Mid Cheshire's demonstrated its ability to set a plan and achieve it. Some really good news around recruitment, and we highlighted, I think, in the report, gave a nod towards really critical areas of recruitment need, and nursing was one of those. And you'll probably know and have heard about in the NHS the challenges to recruit additional nurses. We have managed to recruit in 1 year over 100 more nurses, and if you look at where we were just over a year ago, we had more nurses leaving the Trust than starting in the Trust, and we're now in a position where that's not the case, and we've got 100 more nurses in post than we did back then, which is fantastic news and really good hard work of our personnel recruitment teams, our nursing staff, and all of those people, including my colleagues on the board, who've supported that ambition to really focus on the recruitment of nurses in this last year. We also purchased the private hospital on the Leighton site, and a number of there was a lot of news articles at the time around this, and it was actually the BMI hospital, and they'd chosen to move on. So we actually managed to secure that estate, which was pretty good estate, at a very competitive price, giving us more flexibility for the hospital and better accommodation. Now, obviously, we intended to use that as an operating facility for patients coming in for elective operations. Really fortunately, we'd acquired it just before the COVID pandemic, and the fact that it had all single rooms with ensuite facilities made our management of the pandemic much simpler from an infection control perspective, because we were able to use that facility to give patients individual single rooms when they were at risk of infection or were indeed infected. So therefore, that really was a big help for the organisation. And our estates team did an amazing job of providing increased oxygen facilities and changes to that estate to make sure it was fit for purpose and ready to go. We've prepared for and delivered, I believe, good care throughout COVID-19 pandemic so far. I think the way that the Trust staff approached it, the togetherness of the organisation, but also the way in which we manage some things like the PPE challenges and the health and well-being of staff have been well recognised. And I'm pleased to report, since the annual report was written, we've been shortlisted for 2 Health Service Journal Awards for, firstly, our communications campaign around PPE and making sure staff were using the right PPE, knew what to do, knew how to use it, and also our work on health and well-being of staff and the particular communications campaign about making sure our staff were being well looked after by the Trust. So we're shortlisted for those 2 awards, and we'll know later this year whether we've been successful in that. But I just wanted to publicly record again my admiration and thanks to all of the staff in the organisation for what will have been the most challenging period of their career, bar none, and let's hope that remains so. That brings me finally to our staff, really, and as I said earlier, the fact that they were here and ready to support the organisation, but more importantly to support you as members of the public and our local population in the most challenging time since the NHS was established is testament to them, really. And I want to again thank them for everything that they've done this year. The results that the organisation has obtained, as always, the outcome of the effort that our staff collectively put into achieving it, and all of the benefits and successes that I've described are down to them. So just wanted to say a big thank you again to all of our staff in the hospital, in the community, and wherever they're working. They were the key things, really. The quality account is also attached, so that was a few words on the annual report. For the quality account, you will see that the quality account is a report on the quality of services of the Trust, and it's measured by looking at a number of areas. Due to the COVID-19 situation, the quality account wasn't required to be included in the annual report for this year, and there's a new deadline for submission to NHS England, which is the 15th of December. I've seen the drafts of that we're working on at the moment, which I was referring to, and again, I think when that is submitted and available and people can see it, you'll see good evidence to back up the claims that I was making there around how the Trust has ensured the quality of care for patients during this year, both from a COVID perspective, but more importantly from the everyday perspective of operating as an organisation that treats hundreds of thousands of patients a year in various settings. So that will obviously include feedback from our local stakeholders, including the Council of Governors, who will no doubt review that with us prior to that submission deadline. Okay, that's everything I wanted to say on the key messages from the annual report and the quality account and the changes this year around that. I'm going to hand over now to Ros Davies, our Deputy Director of Finance, who will give you a financial overview of the Trust for the year in question. Thank you. You there, Ros? Please don't tell me I have to do the finance bit as well.
No, it's I've been the first one to do the turn off mute.
Thank you. That's all right.
So if you can just go on to the first slide, Mitch. So within the NHS, under the financial framework, there are sort of 3 key areas that we're measured against. So the first is something called the use of resources rating. So this is how well we are effective at using the money that we are given. And then the second is our ability to accept and deliver control totals from our regulators. And then the final area is our commitment to paying suppliers in a timely way. So that's the target of hitting 95% within 30 days of receipt of goods or invoice. So if you can just go on to the next slide, this just summarises the performance against those financial targets. So against the use of resources rating, we had a target of 3, which we met for our plan last year. and we reported a surplus for the trust. As James mentioned, that was actually higher than what our planned target was. So we delivered a 406,000 surplus against a planned deficit of 1.7 million. Within this, the trust received some provider sustainability funding of just under 8 million. Plus, we also received an additional lump sum at the end of the year of 2.4 million as a result of meeting our financial targets for the year. In terms of the sort of final key area, the trust was below this target of paying invoices within 30 days. However, this was an improvement on 2018 and 19, and it sort of presents our commitment to wanting to work with and support our suppliers. So if you just go on to the next slide, as part of our accounts, we do have a trust charity, and when they're consolidated into our accounts, the overall surplus that the trust made for the year was 634,000. And then the next few slides, I'm just going to take you through some of the key areas of income and expenditure across the trust. So just looking at 281 million that the trust received in 2019-20, the most significant chunk of this comes from our contract income. So this comes from commissioning groups, and actually for us as a trust, about 85% of it belongs to the local Cheshire area. So last year we had 4 commissioning groups across Cheshire, which have now become just one across Cheshire. So they are one of our biggest sources of income, and we also have a very strong working relationship with them. And just on this slide, you can also note within there the overall provider sustainability funding that we received of about 10.3 million. So we just move on to the sort of key areas of where we spend money. It probably won't surprise you that our biggest area of expenditure is around pay, but you can just see the slide of the sort of slice of the pie chart of what we spend on other services in relation to sort of drugs, clinical services and premise costs and other general supplies. If we move on to pay expenditure next, you can see that we do have a significant substantive workforce, but we do also have a reliance on temporary staffing in the form of either agency, but also the trust's staff bank is also another source we have to rely on. So during the year, the trust has developed some successful schemes to try and address the reliance on agency, because we obviously actually do want a substantive workforce where we can get it. So as James mentioned, we've employed a lot of strategies around trying to improve our nursing workforce, which has been a really good success. But we have also looked at exploring alternative workforce, such as the physicians associates, which all go to supporting our services and obviously our patients. And then if we just move on to the next slide, looking at our overall Cheshire population size, the average amount of money that we spent on per person was £860. So we've just done this little diagram just to sort of show just how much we spend on services. So it probably isn't surprising that we spend quite a lot of money on inpatients, but this just gives a bit of a flavour of what we actually also spend on average for outpatients, our community services, our A&E and also our critical care. So that has obviously grown year on year by about £20 per patient. As a trust, if we move on to the capital investments, this slide just gives an indication of just some of the investments that we've made to help try and improve the estate at Mid Cheshire. So it's been an extremely busy year. So we were successful about this time last year in getting some funding to help expand our ED unit, particularly on our majors area. We've also refurbished one of our wards, and we've also replaced one of our CT scanners with a more modern model. And we've also developed a simulation centre on site, which was a really valuable opportunity for training on site for both our clinical staff to do, kind of like real life situations and practice them, but also for supporting services. So it's a very, very nice centre that's been developed to help train our staff. If we go on to the next slide, we can't always take a picture of the IT infrastructure, but it's very much a vision of the trust to use digital technology and enhance our offer to patients. So this year, a big focus of that has been on upgrading our form pathology service, and also looking to enhance a lot of our core infrastructure on the site. But we have a future vision around implementing EPR on site, and lots. I know our IT is very ambitious about what we want to look at. We've also purchased land on site to improve the car parking for patients, and as James alluded to in his last clip, we've also purchased the former on-site South Cheshire Private Hospital estate. So if we go on to the auditor's report, all of the financial statements were submitted on time, despite the challenges of sort of doing all of this virtually online with the auditor. And we actually submitted our accounts early and ahead of deadlines. So we're really pleased that the auditors gave us a qualified opinion. However, they did note that there was an except for comment in relation to value for money. This was really at the backdrop and a common theme amongst trusts, because it came as a result of incomplete planning process. So whereas we'd submitted a draft plan showing a deficit, we hadn't got it to a final signed off plan for 2021, because unfortunately COVID overtook that planning process. There were no misstatements or concerns raised by the auditors, and I'm proud that we also commented on the quality of the finance papers that we presented to them. So if we go on to the next slide, which is looking forward. So historically, we've obviously been on a world of being measured against targets and control totals, but we've had a very different financial regime in the first 6 months of this year. So the trust has been given a baseline set of funding, and any excess above this value has been charged to regulators, which is under the COVID regime. So we actually don't have a fully signed off plan by regulators for 2021 as it stands at the moment, but that is in common with every single trust across the country. In addition, in order to avoid any cash flow problems, the trust has been provided with a favourable cash flow payments, and correspondingly we are obliged to and encouraged to support suppliers, particularly during this time. So we've increased the frequency of payments in accordance with that. So the financial regime for the second half of the year is expected to look to reintroduce control totals, which will be managed at a system level. So that involves a total that works with our CCG, and it's going to have a real focus on delivering the restoration of services at the trust and also supporting key services over the winter period. So as things stand at the moment, I think that's my summary of the finance position. So I think I'm actually the last person to present, so I will go back to any questions and answers.
Okay. Right, thank you, Ros. So now's the part of the agenda where we've got an opportunity to answer any of your questions. If you can put those into the question box on the chat, and we'll do our best to answer them. Just while you're doing that, again, apologies for the IT issues we've had today. We use this technology daily. In fact, we do all of our team briefings and team talks like this, so I'm not entirely sure why today all of a sudden it's failed us, but it certainly isn't the first time we've done it. So my apologies again to those who were hoping to hear from particularly Dennis and Catherine. So if there's any questions, please make sure you get them into the box for us as soon as possible. At the moment, there are none. I will give it a moment before we move on. Okay, so it doesn't look like we've got any questions from the audience today. So that brings me to the final part really of the session today, which is the closing remarks. And again, on behalf of the chairman and myself, thank you all for joining us today. Again, apologies, it's been slightly disjointed because of the problems we've had with the IT. It has been a really useful opportunity to engage with you, which we try and do as often as we can. You'll see there's some upcoming online member events on the current slide there in October and November. So if I could try and encourage you, please, to attend those if you can. I have got a few things coming through on the questions now, which are comments really. I do have something here from Erica, who said a really informative A&E presentation. Do we know what communications are planned for the community to understand the potential benefits of the 111 signposting pilot? So I can certainly say there, Erica, that's our communications team are working with the regional NHS teams on exactly that. I know already we've had some issues where people have potentially understood that to mean something different than what it is. So we're working hard to make sure people will see really clearly what it means and what the benefits are of doing that from their own perspective, but also the perspective of protecting people as well. So we're working on that as we speak prior to go live, and you'll see much more stuff come out over the coming weeks. Gary McCourty said thanks to all, but how many people have attended? That is not something I can see, but one of my colleagues may be able to help me with that.
We've got 35 people currently.
35 people, excellent. Okay, so there you go, Gary, there's 35 people online today. Okay, right, thanks again, and thanks again for your support for the Trust. As always, Trust is here to serve all of you and to do the best we can to look after our local populations, and with your support we'll continue to try and do that. Sorry, this is the problem with live questions. I have got another one just come in. From where were new nurses hired and what is their background? So we had a multiple routes there, Judith. So there was a number of things. So there was some international recruitment from all parts of the world, but on the first round, predominantly Africa. But we also had a lot of people who were returning to practice, others on conversion courses from other disciplines, and some came across from acquiring the private hospital, who were nurses working in the private facilities. There's been a whole mixture of things, and again, we'll talk more in future presentations, but our nursing and HR teams have done a fantastic job of multiple routes of recruitment. So it was a real mixed bag, really, of approaches that seems to have worked. Okay, I'm just checking there aren't any more. Bob Pugh, thank you for this. Is there a consultant presence overnight in A&E? Well, I'll hand over to Seth if he's still there, just to answer how that works out of hours.
Thank you, James. Thank you, Bob, for your question. We currently have a consultant presence in the department from 8 in the morning till 10:30 at night. There's a consultant then on call, and we have a registrar who will be in the department overnight, obviously with a consultant there if needed. We currently have having to staff a 24/7 service with a few numbers is quite tricky, so no one physically in the department overnight unless we're called in, but there is a senior decision maker that is there in our absence. I hope that answers your question okay.
Thanks, Seth. And Bob's also asking, so stay there, Seth, but Bob's also asking about our GPs working in A&E and what plans we've got for that. So I don't know if you want to just pick up the current plan, Seth.
Yeah, of course. So adjacent to ED, we have an urgent treatment centre and a GP out of hours service. So the urgent treatment centre has a GP working until 6:30, and then the out of hours service picks up from 6:30 until 8 o'clock the following morning. We would love to have GPs working in ED. The problem, along with most of the medical workforce, is that the numbers out there just don't exist. I think the thing that we're very keen to sort of impart really is that for the general population, really the best place to see a GP is in their GP surgery, and emergency departments having a GP there is great for the people that potentially turn up and need that GP. but actually we'd rather have our sort of primary care, managing the primary care in the environments that they're used to. I hope again that answers that question for you.
Thanks, Sev. Yeah, okay, so I think every time I say I think that's all the questions, another one appears. So I'm going to say it once and then see if that triggers another one. But if not, I'll bring today's meeting to a close. Okay, yeah, I think that's all the questions for now. So so thanks again for your attendance, everybody, and much appreciated as always. And stay safe and well. And we'll see you all again at this meeting next year, but hopefully many times in between now and then. And thanks to all our speakers today for their contributions as well, which I think were very informative and helpful. Thanks again.